Hi, good morning once again. Uh, we are back on 159th International Weekly Session uh, on 2nd of December, Saturday, 9:30 a.m. Indian Standard Time. We are covering a very important topic, future of monitoring diabetes, time in range, a shift towards the management. We have Dr. Banshi Saboo, who will give us an update about how and what is going on in this topic. He's a chief diabetologist, a chairman of DiCare, Diabetic Care of Hormone Clinic at Ahmedabad. He's honored with fellowship of American College of Endocrinology, American College of Physician, International College of Nutrition, Royal College of Physician. He's an International Diabetic Federation chair-elect for Southeast Asia 23-24. He's an immediate past president of Research Society of Study of Diabetic in India. He is the past president of Indian Obesity Society, AIAARO. He's an honorable vice president of Diabetes in Asia Study of Group. He's an honorable secretary of Diabetic India. He has launched a project of Diabetic Free India 2030, acknowledged by the Honorable Prime President Shri Pranab Mukherjee. He was a founder of NGO Diabetic Care India and Indian Sweet Registry Project. He is a managing editor for a lot of textbooks on diabetes. He's an advisory board member in JAPI, and he has numerous publications in his name. Sir, over to you.
First of all, Saurabh, thank you. Thank you for introducing me and thank you for giving me an opportunity on this wonderful platform. Let me share my screen. Can you see my screen?
Yes, sir, absolutely. You can go on the presentation mode.
Yes, I will do that.
Thank you.
Because this is what we are doing since last 3 years.
Yeah. The world of digital.
Yes, it's a world of digital now. So once again, thank you, IJCP, Saurabh, and all those who are involved in this. And thank you, all the participants, my good friends. Some of them are like Dr. GD, I can see, and many more across the country. And today, what we are going to talk in next 30, 40 minutes, the meaning of glucose control in diabetes. It's really changed. The way we were treating diabetes before a few years, and now the way we are changing, I think the monitoring had really changed, and it has really created a paradigm shift in management of diabetes. I don't have any financial disclosure for this talk. I'm a practicing diabetologist since last 25 years. I'm doing a lot of clinical research, and I'm advisory board member for many of diabetes care pharma companies from India and multinationals too. Let me start my talk with saying that before 102 years, the diabetes mean it was type 1 mostly, and the medication was insulin, which was discovered. So that was the only thing. We were not having anything to monitor that sugar also. We were not having anything how to give that insulin also. It was very crude way of injecting that insulin. And simultaneously, people started talking about the nutrition therapy in diabetes. Rather, before insulin discovery, the people with diabetes were given a very, very low carb diet. That was the only treatment which was available at that point of time. Before 50 years, it was HbA1c and blood glucose monitoring both came. And the establishment of A1C and blood glucose monitoring in almost 40 years back in 1983 in DCCT trial, it was primarily for type 1 diabetes, and that established the importance of blood glucose monitoring and HbA1c, and tried to keep the HbA1c of those patients who are having more than 9. They have targeted it should be less than 7 to reduce the complications in persons with diabetes. And these all patient has to monitor more than 4 times in a day the sugar and insulin. Before 50 years only, a type 2 diabetes patients also started increasing, as we know that, and sulfonylurea was introduced in the market to treat type 2 diabetic patients. almost during the time of DCT when it was getting, and or in 40 years back, there was an insulin pump. It was very old fashioned insulin pump, but the idea was that those patients who are taking, instead of 4 shots or 6 shots in a day, they can inject through insulin pump. In 30 years back, when type DCCT trial ended, UKPDS started, and we were having a lot of other drugs which had also come, like metformin was gold standard. But in last 30 years, there are a lot of anti-diabetic agents were introduced primarily to treat type 2 diabetes. Before 15 years, we were having more of a continuous glucose monitoring, better insulin pump therapy, and then last 5 years, it is advanced insulin pump therapy had come, and a continuous glucose monitoring had also changed the way we are treating diabetes. So it's almost like last 6 7 years we are having different continuous glucose monitoring which we are using in our country. Still, the pillars for diabetes management is, other than medication, insulin therapy, diet, and exercise, it is the glucose monitoring, which is the most important thing, which is, I think it's a one of the strongest pillar for getting tight glycemic control. If I talk about the DCCT and UKPDS, it is that at that point of time, to achieve a tighter glycemic control, it means better A1C, but the risk of hypoglycemia is always increased. But with the introduction of continuous glucose monitoring, we changed our term for A1C and hypoglycemia. For a tighter glycemic control or for better glycemic control, now we use the word how much time in range the person is having his sugar. And at the same time, instead of talking about the hypoglycemia, how much time the person is going below range, that is time below range. So these are the terms is changed in last 5 7 years, as we have now new concept of monitoring, which is time in range. So it's TIR versus TBR that has become very, very important. What I'll be talking about the era of HbA1c and its limitation. Then I'll be talking this novel metrics of time in range, relationship of this time in range metrics with complication, and then I will conclude. As I told you about the DCCT trial, it is HbA1c. The importance of HbA1c was well established in DCCT trial. The persons who are having lesser the A1C have less the complication. This you can see very significantly. The people who are having less than 7, you can see the risk of retinopathy, nephropathy, microalbuminuria, all were very less. But those, as you increase the sugar level or the A1C is high, the complications of microvascular complications significantly increase. So HbA1c level is associated with microvascular and long-term diabetes complication. HbA1c served us in last 40 years, or rather 50 years. It correlates well with average glucose value, because whatever 3 months sugar is there, it is very well correlated. It predicts future complication, as I have shown you the data of DCCT and with UKPDS also. So it's a good risk marker, and all those in 30 40 years, whatever the clinical trials happen, they all evolved or revolved around HbA1c only. It is very easy to measure, because just now with the point of care testing, you can take with the capillary blood also, and even to understand also, because in 40 years we can talk so much about HbA1c, so it's very easy to understand too. It has got medium to long term target setting. So now with different guidelines talking less than 7 or less than 6.5, and those who are elderly or high risk for hypoglycemia and less than 7.5 is also fine. So these are the different setting and targets which we decide for our patients depending on their age, depending on their comorbid condition also. But A1C does not give enough data to answer these questions. What are those questions are? What times of day the person's sugar is high or low? No idea. You cannot have just by getting one report of A1C. Suppose my patient comes with a 7.5, whether I have to get 7 HbA1c for the same patient, how I will do? Because I don't know, at 7.5, patient might be getting hypo also. To achieve this median number of 7.5, and for getting 7.5, there must be some peaks in the day also, which are responsible for his sugar to become 7.5. Now, how I should increase my dose of the medication? No idea, only by seeing HbA1c. Should medication dose be adjusted for these type of patients? And what time of the medication I should give? Because I don't know whether fasting is high or post meal is high. I don't know whether this midnight is low or midday is low. So when I should add the medication, if at all I want to add it? What is going on with food? No idea with food whether it is increasing and how much it is increasing. If sleep gets disturbed, if he's doing more exercise or less exercise, stress. We cannot do any decision only by seeing HbA1c. We don't know what is working. Suppose if I change the therapy, I will have to wait for another 3 months because it will show you the result only after 3 months that HbA1c is really changing or not. And what is not working also, I will able to know only after 3 months. I just made a change, but will it really make a difference? Suppose if I have seen patient today and I have done some change, I don't know whether it is really going to make any difference or not. A patient may come after 3 months with the same reports or maybe more HbA1c also. We don't know because whatever the change which you have done, you will not able to know immediately. The quality of life that we just cannot improve by just seeing the A1C, because the patients who are having on tighter glycemic control, particularly in DCCT trial, they were having a lot of hypoglycemia, almost 60% of them, and the average A1C they could achieve was 7.1, and the hypo was very, very high. So the quality of life you just cannot achieve with the tighter glycemic control. And what experiment should I try going forwards? So no idea that the new medication or the older medication or what are the experiments which I can do. So the quarterly A1C is good to know the average of A1C, average of sugar, but we don't know many answers by just seeing the A1C report. Let me give an example. You can have a two different type of patients with the same A1C, but you can see one patient have a lot of hypo and hyperglycemia, while other patient is having less hyperglycemia and hypoglycemia, and still the A1C is 7.8. So you have these two different type of patients who may come to your clinic, and for the patient with 7.8, now if I want to go further down to less than 7, what should be my approach? Because one patient may have multiple hypo and hyper. That could be the reason for them to have 7.8, while other may have slightly higher only post meal glucose level, and still the sugar is high. Giving you an example, if I do the continuous glucose monitoring with the patients whose HbA1c is around 7.5 to 8, like these are the patients, only one patient with the 4 different days the CGM report. It could be in a type 1 diabetic, more possibility, but 4 different type of patients. Let us see routine type 2 diabetic patients, which is coming to our clinic, a garden variety. You may have A1C of 8, but if you do 4 different type of patients and their continuous glucose monitoring, one patient may have a complete full night, there is a hyperglycemia. Other patient was having hypoglycemia. The third patient was having slightly higher sugar, but it was post meal, all sugars were high. Another patient was having only post dinner sugar. So these 4 different varieties of patients with the same A1C will need different treatment, because these patients need to have HbA1c less than 7. And if I want to titrate the dose of my therapy from 8 to 7, what I should do, because these patients may have different type of glycemic variability. Somebody may have a midnight hyper and somebody may have a midnight hypoglycemia too. So HbA1c does not address the hypoglycemia. It does not give us any idea about the hypoglycemia. With a patient with a average A1C of 7, I don't know how many times patient had gone for hypoglycemia, and a patient of even 7.5 also, we don't have any idea about it. And there is a data now to show that those patients whose HbA1c is even 9 and 9.5 also, they have also multiple hypoglycemia. It's not like that hypoglycemia is not there with the patients who have very high HbA1c also. So glucose experience is more than just A1C. It's not just A1C is sufficient to know about the glucose. It's a overall glucose load in a body is not just average of glucose. It is not the HbA1c which reveal the complete spectrum of risk with people with diabetes. Let me talk about this novel metrics, the time in range in type 2 diabetes. What is exactly time in range? Time in range refers to time spent in an individual target glucose range, which is between 70 to 180. But occasionally, when we want a more tighter glycemic control, it should be between 70 to 140. How much percentage of time somebody is remaining inside that range, below range, that is less than 17, above range, which is more than 180. So that also you can know that how much time is in hypo and hyperglycemia. That is again divided into range 1 and range 2. So I mean below 70 and below 54. Similar way, more than 118, more than 250. Time in range may be used as an appropriate endpoint in a clinical research. and a measure of glycemic control in patient with diabetes. So the person with diabetes, if I have the time in range, it's more better way of marker of monitoring the patients. Emerging evidence suggests that a time in range is inversely correlated to the risk of developing micro and macroscopic complications in patient with diabetes. If I compare HbA1c and time in range, as I told you, time in range gives you single report of last 3 months and average, while time in range gives you continuous glucose value and it compares at any time. HbA1c does not capture any hypoglycemia, while time in range will give you the glucose level and give different times of the day. Any immediate change, if you want to know from HbA1c, no, you have to wait for 3 months, while time in range will give you immediate effects for that. So it has got bad correlation with patient-related outcome. HbA1c does not have that. That is very good correlation with patient-related outcome. That's what reported outcome. The quality of life is better. Definitely, the patient with HbA1c, we know that there are few interference also, while time in range is more costly to get because it requires continuous glucose monitoring. And there is a good correlation of last 40, 50 years of HbA1c with microvascular complication. That much data we may not have time in range because it's a new concept which had been developed. Let me give an example. A one type 1 diabetic patient who is on multiple daily insulin injection with 4 shots of a insulin and 4 times sugar. And you can see here, almost out of 4, 3 of them are well controlled. But if you do the continuous glucose monitoring, you will be surprised to know that actually this patient is getting pre-lunch hypo and post-lunch high. And the midnight sugar is low, even though bad time sugar is normal. So this is the how the CGM can reveal multiple things which a persons with multiple time sugar monitoring will not able to know about all these things. One more data which I want to talk about, the how CGM had really helped the patients. And this is the data for type 1 diabetes as DCCT trial. As I talked, that mean A1C of DCCT trial was 9 with starting of the this clinical trial, randomized control study, but then mean A1C they could have 7.2 after the trial, and severe hypoglycemia rate was 62 per 100 patients here. But with the continuous glucose monitoring almost after 25 years, they have shown the data that their mean A1C has reduced from 7.6 to 7.1, but the risk of hypoglycemia is significantly reduced from 62 to 20 per 100 patients years. This is one consensus which we talked about, the continuous glucose monitoring, how frequently and for whom. All type 1, all who are at the insulin sulfonylurea, all who are at the risk of developing hypoglycemia, hypoglycemic unaware patient, elderly patients with multiple comorbid, they all should be on continuous glucose monitoring. And there are few patients who should be on type 2 also that I will talk later on. Then after 2 years, in 2017-19, we published, I was again the part of both these papers as a international expert. More than 35, 40 people were there from all over the world. I was a part of this consists of CGM data interpretation. It means you can, for those who are garden variety of type 2 diabetic patients and type 1, they should have more than 70% of the time their sugar should be between 70 to 180. If they have pregnancy or type 1 diabetes with pregnancy or type 2 diabetes with pregnancy, the tighter glycemic control 63 to 140. If somebody is a GDM, true GDM, the tighter glycemic control 63 to 140, but then the range of time in range should be more than 90%. So even more than 70%, 90%. The elderly people, it should not be more than 50%, but more than 50% of the time, if they can achieve, please try to achieve that. No risk of hypoglycemia. So it is not acceptable if they go even for more than 1% of the time, the sugar goes less than 70. Our complete idea of treating time patients with a monitoring that we try to always increase the time in range. It means maximum time in a day, they should be in range between 70 to 180. And that is what our aim of treatment for these patients. Luckily, many of these continuous glucose monitoring devices are available in our country, and many of them are on the way. I mean, we will get another 5 years, maybe many more devices in India. We have iPro, we have Libre Pro, they are professional one, and we have real-time one also with CGM, Dexcom, and Libre also. What's the relationship of new metrics with time in range with complication? So if I do the validation of time in range in outcome measure for diabetes clinical trial, this is the data to support that. The patients with type 1 diabetes in the necessity, instead of if we get the time in range for these patients, lesser the complication with higher the time in range. So the better time in range will have less complication. Like the similar way, tighter glycemic control of less HbA1c have better or less complication. Similarly, retinopathy progression, which is also if I do instead of HbA1c, a time in range, I will find they have better or less eye complication or retinopathy complication. If I put time in range and microvascular complication combinedly, you can see that less the time in range, more the microvascular complication for type 1 diabetes. Even for type 2 diabetes also, the glycemic variability is directly correlated with worse clinical outcome, mainly for heart. So they get more clinical problems of heart-related problem because they have more glycemic variability. They may have better A1C, but still they have more cardiovascular problem too. Even diabetes kidney disease is directly correlated with better time in range, less of the risk of CKD also. Even for type 2 as well as for type 1, both studies been done by glycemic variability. Blood glucose variability leads to rapid progression of CAD. So even somebody have a underlying CAD and having multiple fluctuations, that leads to more coronary artery disease. GV predicts that even for end-stage kidney disease in type 2 diabetes with a 10-year follow-up of type 1 diabetes study. It is also been published in some of the papers, particularly from Diabetes Care, that lesser the time in range, more the risk of microvascular complications. It's a known fact and global fact which we are talking of. Even for type 2 diabetes, it is also correlated well with carotid intima media thickness. It means it is also directly related with atherosclerosis too. What are the outcome if time in range is not maintained? Or it is one of the paper of Sanjay, my good friend Kalra, has written that if lesser the time in range, more the complication of retinopathy, nephropathy, and neuropathy risk also. Flash CGM can be used to reduce the diabetes events and hospitalization in patients who are insulin treated. So, I mean, even a type 2 diabetic patients, if they are on insulin, they can have a better control and the less risk of hypoglycemia for that. A1C and time in range is talking about the better the A1C, better the time in range. Better the time in range will definitely reflect in better A1C also. But with only A1C good control does not mean they have a better time in range also. So hypoglycemia in type 2 diabetes is an independent risk of HbA1c. So the patient may HbA1c may have any, but still the risk of hypoglycemia is very high. As I told you here, in the patients who are between 8 to 9, you will find them they are the highest one who are getting hypoglycemia also. The replace trial of flash glucose monitoring reduces the hypoglycemia. The patients were on a multiple daily insulin injection. When they were put on a flash glucose monitoring in replace trial, they have reduced significant hypoglycemia also. There are multiple papers which we have also written from India about the continuous glucose monitoring, the use, and the even the uh, consensus reports also from India. But this is one paper which I have written about time in range is a target for type 2 diabetes. So we should not forget that only type 1 diabetes are only for those patients, but for type 2 diabetes also it's intermittent need. Only thing they may not go for CGM continuously, but they may go intermittently CGM. This is what our paper was for a patient with CGM, how we modified or changed the therapy of type 2 diabetic and still patient is doing more better. The American Association of Clinical Endocrinology first time endorsed the use of time in range in using CGM in patients with type 2 diabetes, using whenever it is indicated or assist the patient in reachable better glycemic control also. The approach for time in range, definitely, it's a well-established concept. Now we should advance it and we should perpetuate it. So more and more people should know about the importance of time in range. Similarly, before 25 years or 20 years when we were talking about the A1C. This is the paper which I was talking that how frequently person should get the time in range. If uncontrolled, maybe every month, relatively controlled every 3 months to 6 months, and even some patients once in a year too. To conclude my talk, at present, we don't have that A1C and time in range or GMI should be done for the people who are on completely oral anti-diabetic agents. But the data is evolving. The similar way, CGM is not very accurate with the persons who are already in hospital because of the inotropic agent. There will be peripheral vasoconstriction and you may not get the right interstitial fluid level, glucose level too. But everywhere, the time in range and A1C is recommended, whether it's a type 1 and type 2 by diet care before few months. The first visit at GLP-1, like let me give an example that how time in range and how CGM had changed the therapy, the way we were treating. So this is one patient before 4 years. It's like how it had changed. One of our patient with a 9 A1C had gone to 2, 3 different consultant, and patient was not ready to take insulin as per the guideline. With a triple drug therapy with HbA1c more than 9, definitely he should be on insulin. So I explained the patient that let us do your CGM, and the CGM was showing all the sugar reports are very, very high. So with this Libre Pro, we asked them patient, let us put you on GLP-1, which will help you for increasing your satiety and will help you to reduce your intake, so your post-meal sugar can come down. We had seen that within 1 day, the patient sugar started coming down, and patient was calling our clinic every alternate day. And by seeing the reports, we were thinking that yes, we should reduce from 4 to 2 milligram to 1 milligram and 1 to half. And then patient again came on 10th day. You will be surprised that all 4 or 5 reports, there is no hypo, no hyperglycemia, 100%. So what I want to show here that the as per guideline, patient should be on insulin. By doing CGM, by getting time in range, explaining the patient, we are getting the best patient for GLP-1 also to achieve a very, very tight glycemic control. At this point of time, I will say that all these three are complementary to each other. They are essential. It's not like that a finger testing is not important. I don't say that A1C is not important. I'm not saying that CGM is also not important. We want all three to work together. They are complementary and they are essential for us. That is what we want. To summarize my talk, HbA1c is the gold standard for diabetes management. However, it does not demonstrate a holistic and a very individualistic glucose profile. Glycemic variability is associated with increased risk of severe hypoglycemia, diabetic complications, and reduced quality of life. Time in range provides a closer view of person's glycemic status. You can know everything and adds in a better glycemic control. Increasing time in range has been shown to have associated with reducing micro and macroscopic complication in people with diabetes. International guidelines have almost all over the world have endorsed it by including ED and including India also. Diabetes India need to exist, move beyond A1C alone, and also consider CGM data for obstetrical diabetes management. With this, I thank all of you for this wonderful opportunity. Thank you, IGCP. I will request all of you for joining our next week diabetes, type 1 diabetes conclave at Aurangabad. We will be also providing you to join online facilities also there. Some of the international speakers and some of the national speakers are joining virtually also, but many of them are there with more than 300 doctors already registered for the meeting. Thank you. I welcome you once again to all of you at Aurangabad for the same. Thank you.
Thank you, Dr. Saboo, for a wonderful presentation. I would like to invite Dr. Chong, our chair for CMAAO, to take the session forward.
Thank you, Dr. Saboo. It was a great presentation. I'm very interested in this area, especially CGMS. What are your thoughts on CGMS in pre-diabetic or non-diabetic patients, who are, let's say, a little bit overweight and obese?
So the data which I have presented, in non-diabetic, particularly for obesity, so it's like a motivational tool for them. And the same for the pre-diabetes also, we have a data, because for prevention of pre-diabetes, sometimes to motivate them becomes very, very difficult. So when putting on a CGM, I think for pre-diabetes, there are a lot of data on a lot of role of CGM, because putting the CGM, you will find that when their post-meal sugar is getting higher, that's a very common challenge for them to reduce their diet and the carbohydrate content. So if they put on a CGM, they will able to know that, yes, this is what food which is really increasing my sugar level. And next time they can modify their diet accordingly. And then they will be also convinced after putting because we ask them to take more fibers, more protein, and more less carbohydrate, more complex carbohydrate. So then they can see that yes, it is really working, and then they get motivated and they continue to use it. I have used for patients for continuously also. I have used for them a pro also. I have used them intermittently more often also to keep them motivated, and it really helps them.
Yeah, nothing like showing them that bowl of white rice they're eating is really shooting their sugars sky high.
Very true, very true. So I mean, seeing is believing. Seeing is believing.
I've got good results when I've shown my patients, this is like instant feedback, instant gratification. The other interesting part, I was wondering, the role of exercise, the muscle uptake of the GLUT4 receptors and so on. I
So
mean,
this
there's
is
also
the
another part that is a bit neglected, right? About muscle and GLUT4 receptors soaking up. I understand that GLUT4 receptors can soak up to 75% of the glucose load.
So this has been in a exercise physiology. We know that,
Yeah.
but using CGM for some of the non-diabetic people, and then those who are using in the gym also, and that there are some
Mm.
apps in India who are for athletics, for non-diabetic people, for exercise doing people, and we have seen that significantly the glucose level goes down, and we want to keep their sugar also at a very less because they are doing really good muscle exercise too. But at present, we don't have any consensus. We don't have any data to
Yeah.
support that the long-term benefit of it. So
Mm.
presently, what I have shown you the data, which is really very robust data, the using continuous glucose monitoring and time in range, particularly for type 1 diabetes. Some data I have shown for type 2 diabetes, some papers and some consensus, and even as algorithm had put that for type 2 diabetes management. For pre-diabetes, our personal experience is very high that we are using it regularly, but still, I think we will be writing more on it on a pre-diabetes. For non-diabetic patients, still data is evolving. We are working on it, but none of us could produce any significant data. Even I have paper on in obesity people using CGM just before some time in Hong Kong meeting.
I would imagine in the type 1, which are obviously a younger group of patients, I mean, over a whole lifetime, they'll be exercising more, having more muscle mass. This part will be a very interesting area to look at, right? The
But
uptake
with
of
the
the.
persons with diabetes. This is
Yeah.
what we are talking, persons with diabetes. Without persons with diabetes, I mean, the persons without diabetes, will it be useful for not? That we don't know.
Mm. I'm quite interested in this whole area because, in Singapore, we have a massive epidemic like everywhere else. We have 11% of the population now who are diabetic, and we're losing our war on diabetes. The rate has just gone up 1% over the last COVID, 3 years of COVID, 2, 3 years of COVID. So, we face a huge challenge here. 1 in 5 by 30 are diabetics, 1 in 3 by 60 are diabetics in Singapore. So, we are we have a huge problem here, which it's so difficult to that's why we're trying to move into this pre-diabetic space and this obese and overweight normal people, so-called still normal glycemic, but it's such a difficult area, and our food culture in Singapore is not good. It's a lot of street food. So street food is
India, it is worse. Believe me. We have the data just recently published in 2022, the ICMR data now 101 million people diabetes, with
oh my God.
136 million people are pre-diabetes. And this is the adult population. So the adult population of India is out of 141.4 billion people. We have more than 40% is young persons. So 60% only. So now adult population, out of them, you can see that how many of them have pre-diabetic and diabetic. So it means like every fifth person. If I take it above the age of 40, you can say every third person will be diabetes in our country. That sort of thing had come.
Wow.
Is diabetes or pre-diabetes? This glycemic definitely.
Huge challenge. This is a huge challenge. Fantastic. I mean, made it scary. Sorry, not fantastic. Scary data. Any questions from the floor for Dr. Saboo? Monica?
Thank you so much, Dr. Chong, and thank you, Dr. Saboo, for your incredible presentation.
Thank
It's
you.
a nice reminder to talk about a very time-proven marker that we're all familiar with the glycosylated hemoglobin, but then to now bring it into the new realm where we haven't had much training in continuous glucose monitoring is actually eye-opening. I agree with Dr. Chong. It would be very nice if all of us walked around with these type of monitors and to get real-time feedback as to what is happening. I mean, we have so many other wearable devices that's giving us our steps and is giving us our heart rate, but it would be also be able to see the glycemic index or the glycemic effect of the foods that we eat so that we can self-correct in real time so that we don't become the statistic as 1 out of 3 Indians, especially who are diabetic. But there is something different about our genetics, and there's something different about our social eating patterns that's making us extremely high risk. And your work, Dr. Saboo, working on our population is very commendable. Thank you.
Thank you, Monica. Anybody else? Has any questions for Dr. Saboo? Yes.
Yes, somebody.
Dr. Bukhari, yes.
Yes, Dr. Bukhari. You have to unmute. Unmute yourself.
Thank you so much, Dr. Saboo. I'm Professor Bukhari from Pakistan.
Wow.
You know,
nice.
similar, more than 3 million people living in Pakistan with type 2 diabetes, more than a country here. My one suggestion and one question is there. What is the role of intermittent fasting in complete remission? Because in our workshops and different practicals, we conducted these in all over the Pakistan, and we saw that so many peoples went in complete remission of the with intermittent fasting. Around about one meal and second meal about 12 to 14 hours distance. One thing is. Second, you are in your lecture, excellent lecture, it was information that with the event of the insulin pump, we think that there are so many types of the diabetes, even without estimating the blood sugar level of insulin. Can you recommend this that in Pakistan, in our situations, the physician recommend even type 2 diabetes on the insulin? What you think? In both my suggestions that before going to suggest the physician to the insulin, we think the level of insulin is very important estimation, because and if we give the insulin, and insulin is already there, we are more putting the insulin and a patient will go on more, will not in a remission state. What is your suggestion, sir, Professor?
So, Dr. Bukhari, for first question regarding
Yes.
intermittent fasting and the reversal of diabetes. Let me tell you, the remission of diabetes and reversal was directly linked with the weight loss. And those who have diabetes of shorter duration, particularly the paper of direct trial, is very clearly shown that those who have less than 5 years of diabetes, particularly the people who are developing diabetes because of obesity, because you have the diabetes of severe insulin deficiency, which may be a lean diabetic patient, and they may not get the reversal. So it is primarily the persons with obesity induced diabetes. Definitely weight reduction have a role to reduce them and get it reverse also. The remission is directly linked with the how much weight loss they have with the obese people. More than 15% of the weight loss, which was there with very low calorie diet, which was primarily a trial which was done in direct trial, had shown that 1/3 of them, almost 33% patient, remain in remission for 2 years. I mean, that's the data which they have shown, and 46% in the first year also. And as you know, that number of years, now they have published their data after 4 years also, and that you can say it's less than 14-15% of the people, because they tend to regain the weight, and because it's a pancreatic dysfunction also associated, it's not just obesity. So you can't say that all people with diabetes will get reversal, but yes, there are subset of the patients, if ideal time you have taken that immediately after detection of diabetes or the pre-diabetic condition, you can prevent them. I will put them as a remission, and it's like a preventing them for a diabetes or preventing them for further increase in hyperglycemia. Now, let me talk about the intermittent fasting. Intermittent fasting means we give them fasting for more than 14 hours. So the primary idea is more than 14 hours is the minimum time. So idea is that you give breakfast not immediately after getting up, rather than slightly late. That is what is required, because God had also asked us to take the breakfast once you get up early in the morning, maybe after 3 and 4 hours, because your glycogen storage is already there inside your liver and your muscle mass, and you can remain in fasting condition for after getting up for next 2 to 3 hours. So go for exercise and take your breakfast, may not be before 10 o'clock or 11 o'clock. Ideally, one should not eat after sunset, and God had not asked us to eat after sunset because there won't be any sunlight. All this is artificial sunlight and where we are eating. So I mean, as per the physiology also, one should not eat after 7 o'clock or 6:30 as the sunset. So if I'm eating between 10 to 6:30 or even 7 o'clock, it means I'm doing a fast of almost like a
14
13
hours.
14 hours, right? So this is a very physiological way. So if someone goes with this physiology, and the data had shown also, there is a significant weight loss.
Yes,
Now,
yes.
for a diabetic patient, if someone who is on anti-hyperglycemic therapy like glitazone, metformin, on alpha glucosidase inhibitor, on SGLT2 or DPP4 or GLP-1, I can think of giving them this prolonged fasting because there is no hypoglycemia risk. But if someone is already started on sulfonylurea, on insulin, the
That
risk
will
of
go into
hypoglycemia is higher. So then I will not ask him to do a intermittent fasting also. So I will put the new word which I had used, and we are using from ADA also, time restricted eating, and that goes more with a physiologic. I mean, so that's a good for everyone, whether you are a lean person or I am a obese person. For every one of us, we should do and follow this time restricted eating. And fasting is a religious also, and why our religions are using it? Because it is anti-aging, it increases your growth hormone, it gives you all those benefits, and that's the reason it is in our religions to do the fasting regularly. So intermittent fasting is one part of it. It's a time restricted eating, which is more physiological. It will help in your weight reduction. The weight reduction have direct impact on a obesity,
sugar.
diabetes management, control of sugar, reversal of diabetes, remission of diabetes, and at least further progression of diabetes will be definitely progress. So these two things are different. Now, let me talk about your second question. You are
Insulin.
talking about the insulin therapy in type 2 diabetes. Now, type 2 diabetes is primarily a insulin resistance followed by beta cell failure. This is a very simple pathophysiological mechanism which I am explaining. So it is a relative insulin deficiency, somebody whose need was increased so much, and now the need is not able to get from your pancreas, which is not able to give that much amount of insulin. So someone has developed diabetes, and now you have multiple medications, like primarily if I talk about the GLP-1, which will decrease your obesity also. So definitely your insulin requirement from your body will also decrease, and they may not require insulin from outside. But what happens with a long term, I mean, a diabetic patients of 10, 15, 20 years who had already used different type of oral anti-diabetic agents by putting them on the sulfonylurea and other agents also. Now, beta cells is already been exhausted. It does not mean that there's insulin level or C-peptide, I have to get it done. Not required, because there's no clinical benefit out of doing it. It may be used for research purpose. But after 10, 15 years, if I'm using different molecules, and after 2, 3 molecules using in a substantial amount, I mean in a suboptimal dose also, in optimal dose also, if I had used, still sugar is not controlled, then using insulin is the right way of treating diabetes, because ultimately glucose is also to be controlled. We have to control glucose and we have to prevent the complications. So use the therapy which will reduce the complication in diabetic patient, which requires A1C, blood pressure, cholesterol management, diet management, exercise, central obesity part of it, and smoking cessation. All these things are to be managed in a diabetic patients. These are all cardiometabolic risk factor. But at the same time, glucose is also to be controlled. So someone with a diabetes of 10 years, 15 years, sometimes, or most of the time rather, I will say, not sometimes, they will need insulin. Now, perioperatively, they need insulin. During pregnancy, they need insulin, because that's the safest way of treating diabetes also. It is the safest way of controlling the glucose also. And the limitation of treating I mean, you may have 3 A1C high, 4 A1C high. These are the only molecule. Insulin is the only way by you can achieve the tight glycemic control. You may not get with a GLP-1. It's a very powerful anti-diabetic agent, but with a person with a HbA1c of 10 or 12, it will not come down to 7. So, I mean, it is not like that for before starting the insulin level, you have to give, I mean, you have to check the insulin for a clinical purpose. No. But you have to, in your clinical practice, you should know when you should start right time. Dr. Akhtar Hussain is also there. I'm so happy to see him.
Dr. Saboo, can I ask you some questions? You mentioned that you don't have to do a C-peptide or a fasting insulin to figure out whether the patient needs insulin therapy.
In type 2 diabetes.
What is your guideline generally? What is your guideline? How many years? Like 15 years, 20 years? Or what was your
There is no guideline. As I told you, it is like there are patients who keep their intensive good control early in the diabetes course. They may not require insulin even up to 15, 20, 30 years. You may see some patients who are in 5 years only, the sugar is never good control and their beta cell get exhausted even in 5 years. So somebody may complain to Dr. Bukhari that, one of my cousin who is not even on insulin after 30 years of diabetes.
Yes.
You are putting me on insulin even within 5 years of diabetes because you two are different. You have different behaved. Your anthropometric data is also different. So, there are reasons. Sometimes you may require in 5 years. Sometimes you may not require even for 30 years also.
Dr. Saboo, my question related to this was that before putting the patient of the type 2 diabetes on the insulin, is it necessary that we should estimate the another thing?
That's completely a clinical situation where you have to use.
Another thing is, Dr. Cho, it is related to Pakistan and India. In Pakistan, we use that is called a raw sugar. That is called in our language we call it good. That is good shakar.
Jaggery the concept also is the same thing, and it also increases the sugar.
Yes, no doubt it is hyperglycemic index is greater. Because in our villages, the people think that this is much.
It's a complete myth. It's complete myth.
Myth, yes, it is related to myth, and the myth increases the immunity.
So, anywhere you go and you should talk about that.
Thank you so much. Thank you so much.
And one last question: What is your own general feel about the GLP-1 in drugs?
It's a fantastic molecule. I tell you, it is the only molecule which not only reduces the sugar, it's an anti-atherosclerotic. It is reducing your obesity. It is the only molecule which actually improves your pathophysiological, because primarily you are targeting the pathophysiological defect of a type 2 diabetes. Out of 8 defects which Defronjo has thought of, that out of them, it is working at 6. Which is, except your gluconeogenesis from kidney, it is almost working on all pathophysiological defects. A fantastic molecule. The data to support like Harmony and all those data, it is showing that even coronary artery disease and stroke is also reduced. So you are you are treating type 2 diabetes not for the purpose of sugar only. You are treating diabetes for not having heart attack, not having stroke, and that helps is done by GLP-1 analog. So I think it's number one and wonderful molecule. The only problem is the fullness. So using GLP-1 for each and every type of diabetic patients may not be right. If you have a lean type diabetic patients who are insulin deficient diabetic patients, elderly people, not having much risk of developing complication, you may not think of. But obese person definitely, and you uptitrate the dose slowly till they tolerate. So it's not like that you start with a high dose. The second big problem for India and Pakistan may be the cost, because these GLP-1 analog, which we are by multinational companies and getting in India and Pakistan, may be very costly. So some of our patients, they can't afford to use it on a regular basis. So one side, you have a significant side effect also. The third problem is patients who have fullness and they don't feel empty, they don't feel hungry, they feel they are not well. So it is considered that if you are not feeling of hungerness goes away, it means you are not well. So that concept is also very high. So patient may come and complain that, sir, doctors have, my weight is reducing, but still I'm not feeling well because I don't feel like to eat. That is also not good. So how you explain, but it's wonderful molecule. And looking for more and more dual GLP, GIP. Probably next year in India, we will have tirzepatide also. We have semaglutide. Injectable. We are waiting.
Yeah, we're all very happy with these new GLP drugs coming out. They are quite incredible. They really solve a lot of problems. But again, price is cost effectiveness is a huge issue. Any other questions from the floor? If not, we're
just one question.
Yes.
Dr.
Just
Cho,
one question,
question
Dr.
to-
Sahu.
Dr. Cho,
Is
question to you.
adding bitter products like Karelega juice or something,
Nothing
Ah.
works. It is
nothing
all.
works?
So, I mean, somebody who is taking the bitter juice and all these things, what happens? The taste goes away, and that's the reason their diet also decreases. And that's the reason they may have some decrease in the sugar level, but there is no direct pathophysiological any mechanism by which they can reduce the sugar. So, it's complete myth. People take it, and we can't say them no, but we keep on telling that it does not work actually. It may decrease your sugar level slightly low, maybe 0.3 HbA1c decrease.
And what about low glycemic diet? Does it affect anything negative?
Definitely, no negative effect, because those foods which have low glycemic index, those complex carbohydrate, those with lot of fibers, is going to work by all means, because it is increasing your satiety value. You will feel full early and your sugar will not increase. So it has to work.
Okay.
Well, the hour's almost up. So if there are
Yes.
no other questions from the floor.
No, Dr. Cho, your background is beautiful. You have pictures.
Thank you.
Dr. Chong is also beautiful.
No, not really.
No doubt.
Thank
Dr.
you,
Cho,
Dr. Saboo.
this is my original library in my. I have library in my home. I am sitting in
lovely.
original library. This is not original. This is original background.
This is not virtual background.
This is not virtual background. Let's stick with it. Yeah.
Thank you. But anyway, thank you, Dr. Saboo. This is a brilliant topic. I mean, so important because we are facing it everywhere, developing world, developed world, everywhere. This is a huge problem. And what you've just said to us is very, very timely, very important, and so crucial in our handling this massive epidemic of diabetes coming our way. I mean, it's a tsunami, so as I always said before. So thank you very much for your wonderful presentation, and really enjoyed the interaction and the Q&A session. And we look forward to having you back again in the near future, maybe talking about something else similar. All right. If no other things from the floor, then thank you very much again, one more time, and much appreciated.
Thank you. Thank you, Saurabh. Thank you, IJCP.
Thank you. Take care.
My friend Prakash from Nepal.
Bye.
Thank you,
Thank you,
Bukhari.
Dr.
Nice
Saboo.
meeting. Dr. Ravi Naidu. Bye-bye.
Thank you.
I will send the recording people who have joined late.
Please.
Thank you.
Yes, Alvin. Nice meeting. Bye.
Thank you.